Today, we are peering inside the mechanism that dictates survival itself, the body's ultimate internal defensive system. We are talking about inflammation and tissue repair, the twin processes of defense and reconstruction.
It's the body's most ancient, most critical internal affair, and, we usually only notice it when it's causing redness, searing pain, or massive swelling. But what the sources you provided reveal is meticulously choreographed molecular blueprint. This isn't chaos. It's a perfectly timed movement of chemical signals and cellular armies. They respond with almost military precision to clear an offender and initiate the cleanup.
Exactly. Our mission today is to move far past the simple concept of, say, a bruise or a scrape. We are performing a deep dive into the specific cellular, molecular, and chemical events, the full supply chain and tactical deployment, really, that dictates exactly how your body responds to everything from a splinter to a serious bacterial infection. We are uncovering that critical, razor-thin line between a necessary, life-saving defense and, well, catastrophic self-damage.
In understanding that balance is everything. At its foundation, inflammation is defined as a vascularized response. Its job is purely logistical. It needs to efficiently deliver host defense molecules, things like defensive white blood cells or leukocytes, soluble antibodies, and the crucial complement proteins, to the exact location of the problem. Whether that offender is a piece of dead tissue, a toxin, or an invading microbe, the essential role is always the same. Clear the threat, prevent its spread, and then trigger reconstruction.
It truly is a universally preserved defense mechanism. And that historical hook our sources mentioned is just fascinating, that the signs were first formally described by a Roman encyclopedist, Aulus Cornelius Celsus, way back in the 1st century AD. Those 4 Latin words: rubor, redness, tumor, swelling.
Calor for heat and duller for pain.
Right.
That's remarkable continuity, isn't it? For 2,000 years, those 4 clinical observations have been the hallmarks. Of course, modern medicine, particularly in the 19th century with figures like Rudolf Virchow, added the 5th crucial element, functio laesa, or loss of function. Historically, we knew what inflammation looked like. But it wasn't until the late 1800s, with discoveries like Elie Metchnikoff's work on phagocytosis, that we started to understand the how. The microscopic cellular mechanisms generating all that heat and swelling.
Okay, let's unpack this core distinction right off the bat because it frames the entire discussion. Acute versus chronic inflammation. This isn't just about how long it lasts, is it? It's a difference in strategy and an outcome.
Oh, completely. They are running on fundamentally different operational clocks. Acute inflammation is the lightning strike. The onset is incredibly fast, often manifesting within minutes or hours of the initial insult. Its primary cellular task force, the troops that arrive first on the scene, are predominantly neutrophils. And crucially, its outcome is generally self-limited. It resolves the issue, often leading to a complete return to normal tissue function. It's the decisive, quick defense.
So acute is the immediate, explosive tactical response. Get in, eliminate, and get out before long-term damage occurs.
Exactly. Now compare that to chronic inflammation. This is the long, grinding siege. The onset is slow, taking days, and it can persist for weeks, months, or even years. The cellular infiltrate shifts entirely. Instead of neutrophils, we see mononuclear cells dominating. That means macrophages and lymphocytes. And the outcome? It's often severe and progressive. It's characterized by these parallel processes of active tissue destruction and, unfortunately, an attempt at misguided repair through fibrosis or extensive scarring.
So that structural difference in cell types, the short-lived plentiful neutrophils versus the long-lived specialized macrophages, that's the body selecting its expected duration of battle. If the neutrophils can't clear it in, say, 48 hours, the system brings in the specialized long-term garrison.
That's the perfect way to look at it. And the initial trigger dictates this choice. The causes of inflammation are, well, they're manifold. They can be external, like infectious agents, bacterial, viral, fungal, or physical traumas. They can be intrinsic, like tissue necrosis. A heart attack causes necrosis from ischemia, for example, or burns or chemical injuries. Even something inert, like a foreign body, a splinter, a suture, even inhaled particles can trigger it. And finally, you have the inappropriate immune reactions, like hypersensitivity and autoimmune disorders, where the body just attacks itself.
And that last category, the immune reactions, that's where we find the dark side of inflammation, the unwanted consequences. While it's absolutely necessary for survival when the process is inappropriate, misdirected, or just goes on for too long, the defense system itself becomes the agent of damage.
That is the critical paradox that defines modern pathology. If the system fails to switch off, the defensive cells and molecules, which are designed to kill bacteria, start inflicting collateral damage on our own cells. The sources detail numerous devastating chronic inflammatory diseases rooted in this failure. We see autoimmune conditions like rheumatoid arthritis, where the joints are continually damaged, and atherosclerosis, which we now know is fundamentally a chronic inflammatory process in the arterial wall, leading directly to heart disease and stroke.
And what's particularly worrying is the concept of low-grade systemic inflammation, often called the silent killer. This isn't a big, acute fight. It's a simmering, low-level process that doesn't cause immediate symptoms, but contributes profoundly to degenerative diseases.
Precisely. We are talking about metabolic syndrome, type 2 diabetes, and potentially even neurodegenerative conditions like Alzheimer's disease. The data increasingly suggest that persistent low-grade activation of the immune system can drive degeneration and tissue damage that remains subclinical, meaning you don't notice it, for years before it manifests as a severe chronic illness. It shows that even a small, persistent leak in the system can eventually sink the ship.
Here's where it gets really interesting. The immediate reaction to injury involves changing the plumbing of the local blood vessels. We're talking about a rapid, localized modification of the circulation designed to maximize the movement of plasma fluid and those defensive cells out of the blood and into the injured tissue.
Think of it as opening the floodgates and slowing the traffic at the same time. Acute inflammation is a sequence of three essential and overlapping components. First, the rapid dilation of small blood vessels, which increases local blood flow. Second, increased vascular permeability, allowing plasma proteins and fluid to leak out. And third, the precise guided emigration of leukocytes, the white blood cells, recruiting them to the focus of injury.
Okay, let's focus on that first step, vasodilation and stasis. This is where the redness and heat come from. Vasodilation increases flow. So how does stasis, the slowing down, happen right after? That seems like a paradox.
It is a dynamic paradox that beautifully illustrates the body's prioritization. Vasodilation is the earliest sign. It's rapid and is often kicked off by mediators like histamine. Increased blood flow to the site explains the redness, the rubor, and the heat, the calor. But immediately following that, the second component, increased permeability, takes over. As all this plasma protein and fluid leaks out through the vessel walls, the blood remaining inside the vessel dramatically slows down. It becomes thick, viscous, congested.
So the body intentionally creates a traffic jam. The initial high-speed flow is replaced by a thick, slow-moving sludge.
Exactly. And this congestion and slowing, or stasis, is absolutely crucial. It forces the leukocytes, which normally just skim through the center of the vessel, to fall out of that axial flow and come into contact with the now sticky endothelial lining.
Ah, so that proximity is necessary for them to start adhering and eventually escaping.
It's step one.
Okay, so that fluid escape raises an important diagnostic distinction: exudate versus transudate. If fluid is leaking out, how do clinicians tell if it's due to active inflammation or something else?
This is a fundamental distinction when analyzing any kind of fluid accumulation or edema. An exudate is the hallmark of active inflammation. It leaks out precisely because chemical mediators have actively increased the vascular permeability. So this fluid has a high specific gravity, a high protein concentration, and it usually contains lots of inflammatory cells and debris.
It implies the floodgates were deliberately opened.
Correct. A transudate, on the other hand, occurs due to passive physical forces, usually changes in osmotic or hydrostatic pressure. For instance, heart failure causes blood to back up, increasing hydrostatic pressure, forcing water out. Or a severe liver disease might cause low albumin, reducing osmotic pressure. This fluid is watery, low in protein, and has few, if any, cells. It implies a plumbing problem, not an active chemical attack.
Let's talk about how the vessels actually open up to allow that precious exudate to escape. Our sources highlight two main mechanisms.
The first, and most common, is the immediate transient response. This is what happens in a minor allergy or a slight trauma. It is very rapid, starting within seconds and lasting only minutes, and is mediated by chemicals like histamine and leukotrienes. These mediators cause the endothelial cells lining the blood vessel to contract their internal cytoskeleton. When they contract, tiny temporary gaps or tunnels open up between the cells, allowing fluid to rush out.
Like a quick, reversible handshake between the cells.
A very leaky handshake, yes.
That's the classic short-lived swelling we might feel when we get stung or scrape ourselves. What about the more severe second mechanism?
That would be the delayed or prolonged leakage. This mechanism involves direct, physical, or chemical injury to the endothelial cells themselves. Severe stimuli like burns, radiation, or potent toxins can cause the cells to just suffer necrosis and fall off, completely compromising the vessel wall. Because the damage is structural, the leakage can begin immediately, but it is much more profound and lasts for hours or even days until the damaged tissue is repaired or the vessel clots off.
So it's profound structural demolition rather than just a reversible gap opening.
Precisely. The vascular changes, the stasis, the stickiness, the leakage, that's all just the setup. Now, we move to the incredibly precise and molecularly complex process of getting the cells from the bloodstream across the endothelium and into the tissue. This is the multi-step recruitment of leukocytes.
It truly is a remarkable feat of traffic management. The blood is still flowing, even if it's slow, and these cells need to be slowed down and convinced to exit at the exact right spot. Our sources detail this as the leukocyte extravasation handoff sequence.
Indeed. The entire process starts with margination, where leukocytes, because of that stasis we discussed, fall out of the central blood flow and just tumble toward the vessel wall.
Yeah.
Then the multi-step handoff begins.
Okay, so step one is rolling. How do they slow down without immediately getting locked into place?
Rolling is all about low affinity, transient binding. Imagine a sticky tennis ball rolling over Velcro. It catches, detaches, and catches again. This is mediated by molecules called selectins on the endothelial surface. P-selectin is key here. It's preformed and stored in tiny vessels called Weibel-Palade bodies, and it's rapidly deployed to the surface in response to histamine, acting as the immediate speed bump.
So P-selectin is like a temporary parking permit, slowing them down enough to check out the situation. But they need the full stop, which is step two. Stable adhesion. What switches the binding from transient to rock solid?
That full stop requires activating the integrins. Integrins like LFA1 are on the leukocyte surface, but they normally exist in a bent, low-affinity state. When the leukocyte senses local chemical signals, specifically chemokines that are embedded in the endothelial surface, those signals trigger an internal cascade. This process causes the integrins to rapidly switch conformation, so they stand up straight and lock into a high-affinity state.
They flip an internal switch that makes them super sticky.
Precisely. These activated integrins then bind firmly to their counter-receptors on the endothelium, like ICAM1 and VSAM1, halting the leukocyte's movement completely. This firm anchoring is vital.
Right, or they'd just be swept away.
Exactly.
Once they're firmly anchored, they have to physically breach the wall, which is step three. Migration or diapedesis? This sounds like the toughest physical challenge.
It is the physical squeezing out of the circulatory system. The leukocytes locate the junctions between endothelial cells, insert a projection, and just squeeze through into the perivascular space. A specific molecule called PCAM1 or CD31 is highly concentrated at these junctions and helps facilitate this transit. They then navigate the basement membrane and arrive in the tissue.
And once they are in the tissue, they don't just wander around. They follow a chemical GPS signal, which is chemotaxis. They follow a literal concentration gradient of breadcrumbs right to the problem.
Chemotaxis is that directed movement. The signals can be exogenous like specific bacterial products or endogenous products generated by our own defense system. The binding of these agents triggers actin polymerization at the cell's leading edge, essentially pulling the cell forward toward the highest concentration of the signal.
What are the key chemical breadcrumbs the body generates to pull these cells?
The three big ones are, first, specific bacterial products. Second, the complement fragment C5a, which is one of the most powerful chemotactic agents the body produces. And third, metabolites from the arachidonic acid pathway, specifically leukotriene B4 or LTB4, which is a very effective recruiter of neutrophils.
And the timing of this recruitment is crucial, the kinetics of recruitment. Why do we get a neutrophil peak so early, followed by the monocytes?
It's a reflection of their respective job descriptions and lifespans. Neutrophils arrive first, typically dominating the infiltrate between 6 and 24 hours. They are highly mobile, they respond instantly to the most common early chemokines, and they're the most numerous circulating white blood cells. They're the shock troops, quick, deadly, and designed for immediate short-term deployment.
So if the shock troops can't win the battle quickly, the heavier, more specialized forces arrive.
Precisely. Monocytes, which become macrophages, they follow. They are slower to marginate and respond, so their peak dominance occurs between 24 and 48 hours. But once they migrate into the tissue, they transform. Macrophages are far longer lived than neutrophils and are essential because they not only continue the fight, but also transition the process toward chronic resolution and repair.
They're the long-term garrison and the cleanup crew rolled into one.
That's it exactly.
Once those leukocytes, especially the neutrophils and macrophages, are finally at the site of injury, they switch from travel mode to attack mode. Their primary job is clear. Eliminate the threat and clean up the debris, primarily through phagocytosis.
Phagocytosis is the body's method of engulfing and destroying. It's a three-stage sequence that must occur efficiently, and it begins with finding the target.
Stage 1, recognition and attachment. How does a phagocyte, say a macrophage, distinguish a harmful bacterium from one of our own healthy cells?
There are a few ways. They have surface receptors, like the famous toll-like receptors, that recognize generic, repetitive microbial patterns that simply don't exist on human cells. But the far more efficient method is through opsonization.
Opsonization, that sounds like molecular flagging.
That's exactly right. The body uses its own soluble proteins as tags. Key plasma proteins like C3b from the complement system or IgG antibodies coat the microbe. The phagocytes have high-affinity receptors for these specific host proteins. This coating acts like a universally recognized flag, significantly increasing the efficiency of attachment.
So the body uses its own defense molecules to mark the target, making the job nearly instantaneous. Once marked, we move to stage 2, engulfment.
Engulfment is the rapid, active process where the phagocyte membrane completely surrounds the particle, extending cytoplasmic projections called pseudopods until the particle is sealed inside a membrane-bound sac known as a phagosome.
And then comes the final, most violent stage. Stage 3, killing and degradation. The phagosome quickly fuses with a lysosome, creating a toxic internal chamber.
That's the phagolysosome, the site of chemical warfare. Inside this chamber, the microbe faces lethal mechanisms, primarily free radicals and potent enzymatic destruction.
Let's detail that chemical warfare, particularly the reactive oxygen species, or ROS, which starts with the respiratory burst. That term always sounds so dramatic.
It is dramatic. The respiratory burst is the sudden, rapid uptake of oxygen used not for energy, but for generating microbicidal chemicals. It involves the enzyme NADPH oxidase, which rapidly reduces molecular oxygen to superoxide anion. This then generates hydrogen peroxide, H2O2.
And H2O2 is powerful on its own, but neutrophils have an extra, even deadlier weapon.
They do. In neutrophils, H2O2 is combined with halides, typically chloride ions, by the enzyme myeloperoxidase, or MPO. This MPO-catalyzed reaction produces HOCl, or hypochlorite.
Wait, hypochlorite, that's the active ingredient in common household bleach.
It is. The neutrophil's ultimate microbicidal system is literally firing household-strength bleach into the encapsulated bacterium.
So that is stunning efficiency.
It is the most potent bactericidal system known in human biology. Macrophages, a little different, also contribute by producing reactive nitrogen species, or RNS. They can produce nitric oxide via an enzyme called INS. NO is microbicidal, and it can combine with superoxide to form highly toxic peroxynitrite, further aiding destruction.
Beyond the internal bleach attack, our sources mentioned a truly surprising, almost self-sacrificial method of external defense. Neutrophil extracellular traps, or nets. Wait, so the neutrophil essentially commits suicide just to kill surrounding bacteria. What limits that process?
It is a high-risk, last-resort strategy that we're only beginning to fully understand. When activated by certain intense microbial signals, the neutrophil undergoes a specific programmed cell death. Before dying, it extrudes a dense, sticky, web-like structure composed of its own decondensed nuclear chromatin, its DNA, essentially decorated with high concentrations of antimicrobial proteins, like MPO and elastase.
A microscopic external net made of DNA and chemical weapons.
Exactly. The purpose is to trap and concentrate these chemicals, preventing the spread of microbes, especially those too large for a single phagocyte to engulf. It's an act of cellular self-sacrifice. However, the debris from nets, particularly the released histones and DNA, can be highly immunogenic. And that's why scientists now believe that uncontrolled or persistent net formation contributes to tissue damage in certain autoimmune diseases, like lupus.
Wow, another example of that double-edged sword of intense defense.
Exactly. Now we shift from the physical combat to the molecular traffic control. The timing, intensity, and eventual stopping of inflammation are all exquisitely managed by a massive network of chemical messengers, the inflammatory mediators. These molecules dictate the whole show.
They are the air traffic controllers, telling the vessels when to open, the cells where to go, and when the battle should wind down. Let's start with the fastest actors, the preformed immediate release signals. The vasoactive amines, histamine, and serotonin.
Histamine is the star here. It's stored preformed in granules, primarily in mast cells, but also in basophils and platelets. Trauma, heat, cold, or the binding of complement fragments can trigger instant release. Its function is primary. It's a mediator of the rapid, immediate increase in vascular permeability and vasodilation. It's the first whistle blast, starting the reaction.
Right. And serotonin.
Released mostly by platelets, has similar effects but is less impactful overall in human inflammation.
Okay. Next, we dive into the incredibly important arachidonic acid metabolites. This is the pathway that gives us that fantastic connection point to so many common drugs we take every day.
This is a huge field. Arachidonic acid is a fatty acid released from cell membrane phospholipids by an enzyme called phospholipase A2. Once it's released, it's metabolized by two major competing enzymatic pathways, the cyclooxygenase, or COX, pathway, and the lipoxygenase pathway.
Starting with the COX pathway, which creates the molecules responsible for the most recognizable symptoms of inflammation.
The COX enzymes convert AA into prostaglandins and thromboxanes. Prostaglandins, specifically PGE2, PGD2, and PGF2, are responsible for three major outcomes: local vasodilation, increased vascular permeability, and acting directly on sensory nerve endings to cause pain, the dolor. And crucially, PGE2 also acts on the brain's hypothalamus to reset the thermostat, causing fever.
And this is why NSAIDs, non-steroidal anti-inflammatory drugs like aspirin and ibuprofen, treat both pain and fever simultaneously, right? They are blocking the signal at the source.
Precisely. NSAIDs are COX inhibitors. They block the activity of cyclooxygenase enzymes, thereby stopping the production of prostaglandins. But the key insight here is the difference between COX-1 and COX-2. COX-1 is constitutively expressed, it's always on, and it performs housekeeping functions, like maintaining the protective stomach lining and regulating renal blood flow. COX-2 is inducible. It's expressed only in response to inflammatory stimuli.
So if you take a non-selective NSAID, you block the bad inflammation from COX-2, but also the protective housekeeping from COX-1, leading to potential side effects like stomach irritation.
That's the critical distinction. It explains why researchers developed selective COX-2 inhibitors to try and suppress inflammation without causing those gastrointestinal side effects. Though that strategy came with its own set of cardiovascular risks, showing just how delicate this chemical balance is.
Right. What about the other branch, the lipoxygenase pathway? This pathway seems to be more focused on cellular recruitment rather than symptoms.
Correct. The lipoxygenase pathway converts AA into leukotrienes, or LTs, which are primarily cellular messengers. Leukotriene B4, LTB4, is that key chemotactic agent we mentioned earlier, powerfully recruiting neutrophils. The other LTS, LTC4, LTD4, and LTE4 are vasoactive, causing significant vasoconstriction and increased vascular permeability.
And those last three, the cysteinoleukotrienes, are particularly important in conditions like asthma, aren't they?
Absolutely. They're incredibly potent bronchoconstrictors, far more powerful than histamine, making them central players in the pathology of asthma and allergic reactions. And it's why some asthma medications are leukotriene receptor antagonists. They try to block these molecules to prevent airway spasm.
Moving on, we have the cytokines, which are the grand communicators of the entire system. These are protein messengers that mediate communication across vast distances.
In acute inflammation, we focus on the primary trio: TNF, or tumor necrosis factor, IL-1, interleukin-1, and IL-6. These are produced predominantly by activated macrophages and endothelial cells. They have local effects, reinforcing the inflammation by activating the endothelium and increasing adhesion molecules. But they also have powerful systemic, or endocrine, effects.
They are the ones telling the rest of the body, we are under attack, mobilize all resources.
Yes, they trigger the systemic acute phase response we'll discuss shortly, including the induction of fever. When released systemically, they can also cause what is sometimes called sickness behavior: malaise, loss of appetite, lethargy, all designed to make the host rest and conserve energy.
Finally, let's allocate the time this system deserves, the incredibly intricate complement system. This is a collection of plasma proteins that requires serious focus.
It is arguably the most complex humoral defense system. Complement is a collection of about 20 inactive plasma proteins that, when activated in a cascade-like domino effect, result in the generation of highly active fragments designed to achieve three primary functions:
Killing microbes, promoting inflammation, and improving phagocytosis?
Exactly.
How does this cascade get started? Our sources mention three pathways that all converge.
The three pathways, classical, alternative, and lectin, are just different ways to get to the critical middle step. The cleavage of protein C3. The classical pathway is usually triggered by antibodies binding to a microbe. The alternative pathway can be triggered directly by microbial surfaces without needing antibodies. The lectin pathway uses a protein to recognize sugars on microbial surfaces. But regardless of the start, they all lead to the cleavage of C3.
Okay, so once C3 is cleaved, what are the key functional outcomes for inflammation?
The first two crucial fragments are C3a and C5a. These are collectively known as anaphylatoxins. They circulate and trigger a powerful inflammatory response by causing mast cell degranulation, which releases massive amounts of histamine.
Which leads to widespread vasodilation and increased vascular permeability.
Right. And C5a specifically is also a powerful chemotactic agent acting as a GPS signal to recruit more leukocytes.
So the complement system acts as an early warning flare, massively amplifying the initial vascular response while simultaneously calling in reinforcements.
Absolutely. The third major outcome is opsonization. C3b, another fragment, sticks like glue to the microbe surface. As we discussed, this highly effective coating marks the microbe for rapid recognition and engulfment. And finally, the full sequence, from C5 through C9, forms the membrane attack complex, or MAC. This is a cylindrical protein structure that inserts itself directly into the cell membrane of the microbe, creating a pore, leading to massive ion flux, and ultimately cell lysis.
It's a highly sophisticated biological torpedo.
It is.
Inflammation isn't just confined to the local site. It sends signals throughout the body, sometimes with dramatic system-wide effects. Let's look at the consequences of those cytokines, TNF, IL-1, and IL-6 acting on distant targets, which we call the systemic acute phase response.
This response involves a systemic reprogramming designed to divert resources toward defense. The most common sign is fever. When these cytokines hit the brain, they stimulate the production of PGE2 in the hypothalamus, which acts like turning the dial up on the body's internal thermostat.
So fever is an intentionally mediated defense strategy, not just a sign of the body malfunctioning.
Precisely. A second major effect is on the liver, which is signaled to drastically alter its protein synthesis. It begins synthesizing acute phase proteins, or APPs. The most clinically significant are C-reactive protein, or CRP, and serum amyloid A.
We hear about CRP tests all the time. Why is it so useful as a clinical marker?
Because CRP acts as an opsonin, it can bind to microbial surfaces and activate the complement cascade, so it aids in defense. But crucially, its concentration in the blood can rise 100-fold in response to systemic inflammation. Doctors use an elevated CRP level as a nonspecific but highly sensitive indicator that active systemic inflammation is present, helping them track disease activity.
And finally, the mobilization of forces from the bone marrow, leukocytosis.
This is the dramatic increase in circulating white blood cells. Cytokines and other factors signal the bone marrow to accelerate production and release of new cells. The type of infection often dictates the cell released. A typical bacterial infection triggers a significant increase in neutrophils, what we call neutrophilia. Viral infections, conversely, often cause an increase in lymphocytes, or lymphocytosis.
Which allows doctors to quickly infer the nature of the offending agent based on a simple blood count. Moving from the system-wide effects back to the local injury, let's give the listener a visual context with the morphologic patterns of acute inflammation. This describes what the reaction actually looks like in the tissue.
These patterns provide diagnostic clues about the underlying injury. The mildest form is serious inflammation. This involves the exudation of thin, watery fluid, often into spaces or surfaces, with very few inflammatory cells.
A simple skin blister from a burn or friction is the classic example, right? It's mostly plasma fluid.
That's it. Now, if the vascular leak is more severe,
And you get fibrinous inflammation.
right, this occurs when the vascular permeability is so high that massive plasma proteins, including fibrinogen, escape. Once outside the vessel, fibrinogen is converted into fibrin, forming a thick, gooey meshwork. This is often seen in body cavities like the lining of the heart or the lungs. If the body fails to clear the fibrin, it can organize into scar tissue, potentially obliterating this space.
And the pattern everyone recognizes, the most obvious sign of a serious infection, purulent or suppurative inflammation leading to an abscess.
This is defined by the production of pus, a thick, creamy yellow fluid that is a purulent exudate. Pus is a grim mix. Millions of dead or dying neutrophils, liquefacted necrotic cellular debris, and the causative microbes. And when this collection of pus is localized and walled off within a confined tissue space, it forms an abscess.
Why do abscesses often require surgical drainage? Can't antibiotics handle it?
Because the abscess cavity is walled off and full of dead, acidic debris, it's virtually avascular. So antibiotics often cannot penetrate the center at concentrations high enough to kill the bacteria. Drainage is necessary to physically remove the offending material and allow the systemic defenses to clear what's left.
Got it. And finally, the ulcer.
An ulcer is a localized excavation or defect on the surface of an organ or tissue, created by the sloughing off of necrotic tissue that was destroyed by the underlying inflammation. Peptic ulcers in the stomach lining or severe chronic skin defects are characteristic of this pattern, often reflecting a failure of the epithelium to repair itself over a site of intense, prolonged destruction. Let's return to the sustained battle. Chronic inflammation. Where acute inflammation is a decisive sprint, chronic inflammation is an enduring, prolonged battle characterized by concurrent tissue destruction and misguided attempts at repair.
And the dominant cell type shifts entirely, making the macrophage the masterpiece of chronic inflammation. They persist for months or years, effectively running the entire show.
They truly are the pivotal cell.
Yeah.
Circulating monocytes migrate into the tissue and transform into activated macrophages, and their role is highly nuanced. They're responsible for destroying the persistent offender, but simultaneously, they are the main architects of the repair and fibrosis process. To understand chronic disease, you have to understand their dual identity.
And this brings us to the concept of macrophage polarization, the M1 versus M2 activation states. This sounds like the future of anti-inflammatory therapy.
It is absolutely central to therapeutic development. Macrophages are highly flexible. Classical activation, or M1, is induced by powerful microbial products and, critically, by the cytokine IFN-gamma, which is released by T lymphocytes. M1 macrophages are the warriors. Their primary function is high-intensity killing. They secrete the greatest amounts of ROS, NO, and pro-inflammatory cytokines like TNF and IL-1. They kill bacteria and also promote massive localized tissue destruction.
So M1 is the defense force, focused purely on eliminating the threat, regardless of collateral damage. What about the M2 state?
Alternative activation, or M2, represents the repair and maintenance crew. M2 activation is induced by different cytokines, notably IL-4 and IL-13. Their function is not killing, it's reconstruction, anti-inflammation, and immune modulation. They are essential because they secrete potent growth factors, particularly TGF-beta, and promote angiogenesis and collagen synthesis, leading directly to fibrosis.
And that dual role creates the pathological feedback loop in chronic disease. The M1 cells destroy, and the M2 cells immediately try to patch that destruction with dense, non-functional scar tissue, making the organs stiff and less functional.
Precisely. And this persistent cycle is heavily reinforced by the lymphocyte role. The T lymphocytes surround the macrophages and constantly secrete IFN-gamma, which keeps the macrophages locked in that M1 inflammatory tissue-damaging state. This relentless macrophage-lymphocyte interaction is the fundamental driver of autoimmune and long-term chronic diseases.
And when the body encounters an exceptionally persistent agent, it creates an extraordinary structure called granulomatous inflammation. This is a highly specialized, desperate containment mechanism.
A granuloma is the body's attempt to construct a microscopic cellular bunker around an offender it cannot eliminate quickly, like the bacteria causing tuberculosis, certain fungi, or non-degradable foreign bodies.
How is this bunker structured?
It's a localized collection of those activated macrophages, but they morphologically change. They transform into large, flattened cells resembling epithelial cells, which we call epithelioid cells. These epithelioid cells often fuse together, forming massive multinucleated giant cells, which can contain dozens of nuclei. This core of giant cells and epithelioid cells is then tightly contained by a surrounding collar of activated T lymphocytes.
So the T cells are the guards on the perimeter, constantly secreting IFN-gamma to keep the inner wall of macrophages maximally activated and contained.
Exactly. It's a living wall built by the body to physically wall off the invader and prevent its spread, even if it means sacrificing that small area of tissue function. Granulomas are a defining feature of diseases like TB, leprosy, and even Crohn's disease.
Once the battle is over, whether it was acute and resolved or chronic and contained, the reconstruction phase begins. The body has two very different strategies for repairing the defect created by injury and inflammation.
These two strategies are the ideal, regeneration, and the necessary fallback, scar formation or fibrosis. Regeneration is the gold standard, replacing the damaged components with tissue that is structurally and functionally identical to the original. For this to happen, two conditions must be met. The remaining cells must be capable of proliferation, and the underlying connective tissue scaffolding, the ECM, must be largely intact to guide the new growth.
But if that scaffolding is damaged or the cell type can't divide, the body has to resort to scarring.
Scar formation is the repair of the injury by depositing dense connective tissue. It saves the structural integrity of the organ, but it's always accompanied by a loss of function. A scar in the heart holds the wall together after a heart attack, but the cells in that scar can never contract again.
The viability of regeneration depends entirely on the cell's proliferative capacity. Let's review those three categories of tissue types.
First, Labile tissues. These cells are constantly dividing and being replaced throughout life. Examples include the skin epidermis, the epithelium lining the entire GI tract, and the hematopoietic cells in the bone marrow. These tissues have an enormous capacity for complete regeneration.
Then we have stable tissues.
Stable tissues are usually quiescent. They're in the georest stage, but they can rapidly re-enter the cell cycle and proliferate if stimulated by injury. The classic example is the liver, which has a remarkable capacity to regenerate up to 75% of its mass. Other stable tissues include the kidney, pancreas, and fibroblasts themselves.
And the tragic third category, the tissues that cannot regenerate at all. Permanent tissues.
Permanent tissues are non-proliferative. Once they are gone, they are gone. This includes the neurons of the central nervous system and cardiac muscle cells. This is why any significant damage to the brain or the heart, such as from stroke or a major myocardial infarction, always results in repair by scar formation.
Always fibrosis, leading to a permanent functional deficit.
Always.
Let's focus on the actual mechanics of scarring. Our sources detail specific steps in scar formation or connective tissue deposition.
Scar formation is a highly organized, sequential process. It starts with angiogenesis, the rapid sprouting of new blood vessels from existing ones. This is critical for bringing essential oxygen and nutrients to the repair site. This process is heavily mediated by VEGF, vascular endothelial growth factor.
This high density of new vessels, combined with the influx of other cells, leads to the appearance of granulation tissue. What is this tissue functionally?
Granulation tissue is the temporary biologic scaffold that fills the defect. It's highly vascularized, soft, and characterized by proliferating fibroblasts, newly formed capillaries, and scattered macrophages. It's pink, moist, and granular, and it must form before the permanent scar can be laid down.
So granulation tissue is the foundation. What transforms that temporary scaffold into the dense permanent scar?
That's the critical phase of collagen deposition. Activated fibroblasts, prompted by signals from M2 macrophages, begin synthesizing and secreting massive amounts of collagen and other ECM components. And remember that key M2 secreted growth factor. TGF-beta is the most potent and important cytokine for driving this fibrosis and collagen synthesis. As the process matures, the vessels regress, the cells decrease, and the highly vascular granulation tissue turns into a pale, relatively avascular fibrous scar.
And the final step is dynamic, remodeling. The scar doesn't just sit there, it's constantly being reshaped.
It is always being remodeled. Remodeling is the process of adjusting the balance between new collagen synthesis and old collagen degradation. This degradation is achieved by a family of enzymes that act like microscopic molecular scissors, the matrix metalloproteinases, or MMPs. These are released by fibroblasts and macrophages and are tightly regulated by counterenzymes, the TIMPs. The ongoing balance between MMPs, the cutters, and PIMPs, the inhibitors, dictates the final structural strength and quality of the mature scar. We conclude our journey by looking at the real-world application of tissue repair, specifically wound healing in the skin. The final outcome is entirely dictated by the nature of the initial defect.
Let's look at the difference between healing by first intention and second intention.
First intention is the fastest, most efficient route. It occurs in clean wounds with minimal tissue damage and edges that are closely opposed. Think of a simple, clean surgical incision closed by sutures. There is very little inflammation, minimal need for granulation tissue, and epithelial regeneration quickly bridges the small gap. The resulting scar is small, neat, and linear.
Second intention, conversely, sounds like the body is facing a much harder job.
It is far more complex. Second intention healing occurs in large defects, ulcers, severe burns, or wounds with separated margins where there has been significant tissue loss. Because the gap is large and there is often more necrotic debris, the inflammatory reaction is much more intense and prolonged. It requires extensive granulation tissue to fill that massive defect from the bottom up.
What is the defining structural difference in second intention healing that produces a bigger scar?
The key mechanism here is wound contraction. Second intention relies heavily on specialized cells called myofibroblasts. These are essentially fibroblasts that acquire the contractile properties of smooth muscle cells. They grab the wound margins and actively pull them inward, physically shrinking the size of the defect. This is necessary to close large wounds, but the extensive granulation tissue and the contraction process result in a much larger, more disfiguring residual scar.
Finally, we have to address the pathological outcomes when the repair system goes rogue.
The sources outline a few critical abnormalities. First, chronic wounds, which are persistent defects that fail to complete the normal healing cascade, often stalling in the inflammatory phase. Diabetic foot ulcers. venous leg ulcers, or pressure sores are common examples, usually stemming from persistent infection, poor blood supply, or underlying systemic disease.
And then there's the issue of excessive uncontrolled scarring.
We distinguish between two types. A hypertrophic scar is an excessive accumulation of collagen, forming a raised, fixed scar, but it remains strictly confined within the boundaries of the original injury. These often respond to treatment and may regress slightly over time.
But the more aggressive type, the keloid, grows outward.
Correct. The keloid is an abnormality where the scar tissue grows robustly and invasively, extending beyond the borders of the original wound. They are much harder to treat, rarely regress spontaneously, and unfortunately show a higher prevalence in certain populations, like those of African descent.
That distinction, confined versus growing invasively beyond the boundary, is critical for diagnosis.
It is. The final pathological outcome is contracture, which is excessive, uncontrolled wound contraction. While contraction is normal in second intention healing, when it is excessive, it leads to serious physical deformity and functional impairment, particularly around joints or in the palms and soles. It's a major complication following severe burns.
That was truly a comprehensive dive into the microscopic molecular battle raging inside us every day. We saw the entire sequence from the initial vasodilation signal creating the sticky environment through the complex selectin-integrin handoff to the decisive chemical warfare inside the phygolysosome via hypochlorite, the body's own bleach.
We navigated the transition from the acute decisive defense to the chronic smoldering fight, driven by the mononuclear tango between lymphocytes and the polarized M1 for destruction and M2 for repair macrophages, sometimes forcing the system to construct the protective cellular bunker of the granuloma.
And we finished with the reconstruction phase, balancing the ideal of regeneration, the liver's remarkable capacity, with the necessity of scar formation in permanent tissues like the heart and brain. It's clear that inflammation is not a malfunction in and of itself, but a complex, critical defense strategy that, when mismanaged or misdirected, becomes the source of profound chronic illness.
And that leads us to a provocative final thought, building on what our source material highlighted about so many common debilitating chronic diseases: atherosclerosis, COPD, arthritis being fundamentally chronic inflammatory processes. We spent time detailing the fine balance between M1 macrophages for destruction and M2 macrophages for tissue repair and fibrosis. So consider this. If a persistent low-grade stimulus, whether from metabolic stress, environmental irritants, or even the remnants of NETs, causes the system to continually lean toward that M2, fibrosis-promoting phenotype over many years, that subtle, persistent overproduction of connective tissue accumulates until it leads to structural organ failure. We recognize the danger of acute intense inflammation, but what does that silent, slow, chronic activation truly mean for long-term organ viability? And how might future therapies evolve from broad end stages to exquisitely targeted treatments that specifically promote the M1 to M2 transition at the right time, thereby clearing the inflammation without triggering excessive fibrotic damage?
An immense concept is the body's overzealous chronic repair mechanism, eventually what causes the long-term failure. We leave that for you to ponder and explore.
Thank you for providing the material that allowed us to make this deep dive.
We'll see you next time.